discussing about the journals to this month, and there are quite interesting articles which have come with regards to a mixed bag in pediatric endocrinology. Why really do we need to do a literature review? That is a key question which often we will ask, and often if we do not look into the literature, we will be left behind in terms of what new developments are happening. So the 4 points we want to look at in a paper which is coming is it valid? Is it generalizable? Particularly if it's been done in a different environment, is it valid and generalizable for our population? Is it a novel work which warrants a change in our practice? So this is what are the 4 criteria that we'll try to assess all the 4 journals and try to see if we need to change our practice from that perspective or not. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of innovative resources and courses. We have got fellowship programs and diploma programs in pediatric endocrinology. There are 3 programs which we run every month. One is a grand round, then this is journal club, and then we've got a PG lecture series which is run from that perspective. There are publications and mobile application improving the outcome in the setting of type 1 diabetes management and how technology can help and how monitoring can help. So Dr. Dhwani will talk about this study which is being published in JCEM.
Teamwork targets technology and tight control in newly diagnosed type 1 diabetes patients. So we know that we've come a long way in the diagnosis and management of type 1 diabetes. The ancient scriptures describe classical symptoms of polyuria, polydipsia with early deaths in children, but it was not until Oskar Minkowski and Joseph von Mering discovered the role of pancreas in causation of diabetes, following which Paul Langerhans described the beta cell of pancreas. And we know that Banting and Best isolated insulin, and MacLeod and Collip helped in purification of the animal extracts of insulin. This is when we came up with the management of insulin. Even as far as the management is concerned, once insulin was discovered, we came with better insulin delivery devices, from syringes to pen to the continuous infusion pumps. So we know that the management of insulin has diversified significantly. Even looking at the diagnostic modalities, we had initially the urine dipstick, then we moved on to the self-monitoring blood glucose device, and now to the continuous glucose monitoring devices. So the step forward in management of diabetes, it has been progressive. Landmark trial in type 1 diabetes management was the DCCT trial, which studied over 4,000 patients over a period of 15 years. And the results found were that superiority of intensive blood glucose measurement and control in reducing the incidence of complications in type 1 diabetes. Maintaining HbA1c around 7 reduced the risk of long-term complications, and period of sustained glucose control helped to protect against long-term complications, even when the aggressive therapeutic options were stopped. Also, there has been study to show that clinically meaningful and lasting HbA1c improvements are rare after first 5 years of type 1 diabetes, and that uninterrupted continuous glucose monitoring access is associated with decrease in HbA1c in youth with type 1 diabetes. So this is how the idea for study was initiated. This was a single-center cohort study which looked into so there was a historical cohort. These were the patients before initiation of study who, like all our diabetic patients at diagnosis, the family was counseled about the diagnosis, the treatment options, the long-term care, and diet and exercise. Then there was a fellow attached to every patient who, for the first 2 weeks, helped the family with diabetes care of the child. And first visit was scheduled at 1 to 2 weeks post-diagnosis, again in which the family interacted with the physician, the diabetes educator, and subsequent visit was at 1 month, and then 3 monthly visit, which is pretty similar to what our diabetic patients go through. These patients may or may not be started on CGM or other glucose monitoring devices, and there was no set point to when this technology was introduced in these patients. And then we had the pilot 40 cohort. So this included youth, children with type 1 diabetes with newly onset type 1 diabetes. And again, in this In this cohort, the family was counseled about the diagnosis, the treatment options, like in the historical cohort. However, within 3 days to 2 weeks post-diagnosis, a visit was made to initiate CGM initiation. And in the first week of CGM initiation, the family was in contact through teleconsultations to help the family adjust with the CGM device. Similarly, again, the first visit was at 1 to 2 weeks, at 1 month, and then 3 months.
Essentially, they were doing CGM in everybody,
Yeah.
and they were in touch about the data. They knew the data, and they informed about changes.
Yes. So the sample size was calculated to about 120 patients. This was powered at 93% to detect a 0.5% change in HbA1c.
And when was the HbA1c measured?
HbA1c was measured 3 monthly.
Okay. And how long was the duration of follow-up?
1 year.
The big problem here might be that there is a honeymoon phase happening, and some
Yes.
people may be in different phases. So that may be a bit of a
So the primary outcome studies was a difference in HbA1c at 4 to 12 months post diagnosis, and the secondary outcome study was proportion of children achieving an HbA1c of less than 7.5%, because the study was initiated in about June 2018. So they used the ADA cutoffs of 7.5%, which was defined then. So what they got was, in the historical cohort, they had about 272 patients and 135 in the pilot 40 cohort. The age at diagnosis was at 9.7 years in both these cohorts, with 50% male population. HbA1c was maximum at diagnosis, with 10.7% in the historical cohort and 12.2 in the pilot 40 cohort. CGM initiation was in 56.2% of the patients in historical and 100% in our pilot 40 cohort. Also, CGM initiation, if you look at it, early initiation within first 30 days was in only 1.8% of the historical cohort. Days to CGM initiation, median of 7 days in our pilot 40. And again, another thing that we need to look at is the days to pump initiation was earlier in the CGM group.
And how many were on pumps? Did they mention that?
Yes. So
pump use was around 50%. So 50% was on pump, and it went out around 1 year.
Yes.
They followed on pump.
So what they found out was, initially they were doing HbA1c, but because of COVID-19, there was a transient gap where they could not. The study was from June 2018 to June 2020. So they had calculated the glucose management index, which is a rough estimate of HbA, similar to HbA1c. So what they found out was that the glucose management percentage was minimum at 4 to 4th month post-diagnosis, and after which it gradually increased. Again, looking at the average CGM, which it was a mirror of the GMI, lowest at 15 to 20 weeks post-diagnosis, and after which it gradually increased. Time in range was again best at 4th month post-diagnosis, after which it gradually decreased.
So this was probably because the beta cell functions are going down.
Yes. So again, looking at it, the HbA1c in the pilot 40 cohort was slightly higher as compared to the historical. It with initiation of therapy, it went down in both these cohorts. And again, you may see that the 3-month value is higher for HbA1c as compared to the historical. But if you look at the difference, it is better in the pilot 40 cohort. Beyond this period, the values only increased. Beyond 3rd month, the HbA1c increased. But if you look at the graph, the rise in HbA1c value was steeper for the historical cohort as compared to the pilot 40 cohort. Now, even within the pilot 40 cohort, there were 2 groups. After January 2019, what they also started doing was 2 monthly CGM recordings were accessed by the caretaker team, and based on the based on those CGM readings, the insulin doses were titrated. So patients before January 2019 were not being remotely monitored, and after 2019 were being remotely monitored, and therefore more frequent changes in their insulin dosages were being made. So again, as we can see, in those that were remotely monitored, we see that the best was again at around 4 months, and beyond which there was a steady rise in HbA1c, which was slightly steeper for the children who were not remotely monitored. However, this difference was not found to be statistically significant in our study. So now that we've seen HbA1c, let's look at the time in range, which was their secondary outcome. So the first one is defined for time in range of, this is HbA1c less than 7.5% in the first one. So we can see that by, even though in the first 3 months, 75% of historical cohort had achieved an HbA1c of less than 7.5%. Beyond this period of time, it was the pilot T4 cohort who had HbA1c less than 7.5. And the second graph lower down is for a tighter control looked at HbA1c of 7%. So as we can see, it was the pilot 40 performed better. Looking at the time in range, more than 60% of the patients in the pilot 40 cohort had time in range, with very few in the hypoglycemic side. If you look at it, best control, as we know, around 4 months was the best control. So 74% were in the time in range in the at the 3-month period, after which it gradually decreased, but it remained above 60%. The proportion of hyperglycemia was about 20% and about 5% in the hypoglycemic part. So what does this study mean for us? The age group that was defined is roughly similar to the type 1 diabetes cohort that we see in our setting. It had 50%, there were 50% males and 50% females in our study. The only thing that we cannot reproduce in an Indian setting is the availability and the access to CGM devices. But
now, if you look at overall, you're talking about a CGM associated causing a 0.5% decline in the HbA1c pretty much. That's what I'm saying. So, what about the other evidences that you have? Have you looked at other studies as to how much CGM decreases the figure? Generally speaking, if you talk about 4 groups of people, one who is on simple insulin, no CGMS, basal bolus with CGMS, pump with CGMS, and pump without CGMS. The best are pumps with CGMS. The second are actually CGMS. And then CGMS, if you just give pump without CGMS, it will not be of much benefit. So monitoring actually itself is a very, very important goal. So I would think that this 0.5 figure is a slightly lower figure in terms of the impact of CGM which we are seeing. The reason for that is that we are talking about a phase when you already have a very good control. So this is the time when your honeymoon phase is there. So if they had carried it forward for 2 years, 3 years, then the difference will widen up. So patients who are actually monitoring CGM, and we don't know how many of them are continuing CGM on it later on. Yes. If they continue CGM later, it will be benefit. But the major benefit that is coming from here is from CGM, which probably will be a bit of an issue in terms of using everybody. But if somebody can afford it and you can give it in the initial phase, you will get a good outcome. That's what it is telling us.
So we know that CGM will help us achieve a tighter glycemic control. It will allow us to tailor dietary and insulin prescription. It will also allow remote access, so we can look at the graphs that the CGM sugar monitoring in the CGM device and provide remote access, remote care to our patients. Also, the patients may not need to maintain with the newer generations of CGM, where you may not always require checking calibration with blood sugar values. The patients are free of maintaining logbooks, and there will be no chance of falsely reported values, which we commonly come across in our OPD setting. The future potential with CGM is that if combined with automated insulin delivery, it may safely allow us to lower the glucose targets in youth with diabetes. And if it is incorporated with exercise and physical tracking, it will help us give tailored advice to children about physical activity that they should and can do.
So I think this is a good study. And it really shows us that this is the way forward. But at the moment, the technology benefits you expect is not huge in terms of that. So now we have had discussions about four very important topics. One was about the use of a novel drug for the management of childhood obesity. Then we talked about the effect of maternal thyroid dysfunction on outcome of neurodevelopmental. We talked about the various parameters, and what we found was that it may be good to actually stick to a fasting PP and HbA1c rather than go ahead with other parameters. And CGM initiation at diagnosis would be a good parameter. All of you can go and have a look at our website, the courses, and the mobile application.